cloud.
Hi, everyone. Welcome to the Prevention Subcommittee for the Substance Use Response Group. I'm going to give our colleagues at SEI a moment to just admit everyone from the waiting room, and then we'll get started.
I have one more person coming in from the waiting room, and I'll let you know when that's clear. All right, I think we can go ahead and get started.
Wonderful. Hi, everyone. Welcome to the SURG Prevention Subcommittee meeting, November 5th, 3 o'clock. So grateful to have all of you here. We are going to start with agenda item number 1, which is a call to order and roll call to establish quorum. Before we complete the roll call, I just want to note for the record that we will be taking an agenda item out of order today. We'll take agenda item 6, which is discuss proposed discuss proposed prevention subcommittee recommendations, and agenda item 7, the presentation on the substance use prevention allocations. They'll be swapped. So we'll take 7 and then we'll take 6, just for the record to note. Kim, can I turn it over to you to establish quorum and call to order?
Yes. All right. When I call your name, if I could ask you to please indicate that you are present. Okay, Chair Johnson.
Present.
Okay. Vice Chair Schoen.
I am here. Good afternoon.
Member Nichols.
Present.
Thank you. Senator Donate. Right. Member Morgan.
I'm here.
Thank you. All right. Member Shanae.
I am also here.
Thank you. And Member Lance.
Present.
Thank you. Did I miss anyone? All right. All right, Chair Johnson, we have quorum.
Fantastic. Thank you so much. We can, before we move on to public comment, Kim, is this an opportunity for our new members to share, or is that better served later on the agenda?
We do have that later on the agenda.
Fantastic. Looking forward. I know for any of you tuning in today, you see we have some new members, so we'll give them a chance to share more about their background later on the agenda. With that, let's turn over to item number 2, which is our period of public comment. I'm going to turn it over to my SEI colleagues to ensure we're compliant with open meeting law related to any public comment.
Thank you. Okay, so public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment should be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. If you're dialing in from a telephone, dial 253-205-0468. When prompted, enter the meeting ID 825-0031-7472. Please press 06 so we can prompt you to unmute. Members of the public are requested to refrain from commenting outside the designated public comment period unless specifically called upon by the chair. We also ask that people do not use the chat for items other than technical support, as this becomes part of the public record.
Thank you, Kim. I did want to note, I believe you said press 06 so the host
Oh,
can
I'm
unmute
sorry.
you, but it is
Sorry,
star
star
6.
six.
Just
Thank you.
for the record to reflect correctly. I appreciate that. Do we have anyone for public comment?
I am not seeing anyone for public comment.
Okay, thank you. We can go ahead and close agenda item number 2, public comment, and we'll move on to agenda item 3. This is to review and approve the minutes from our June 4th Prevention Subcommittee meeting. You may be wondering why we're approving June minutes, and this we didn't have quorum at the August meeting in order to approve our June minutes. So my request today is the opportunity to both review and approve our minutes from our June 4th Prevention Subcommittee meeting. When folks have had an opportunity to review, I'd entertain a motion to approve the minutes.
Johnson, so moved. Eric, shown for the record.
Thank you, Mr. Schoen. Do I have a second?
This is Stacy. I'll second.
Thank you, Stacy. All in favor, say aye.
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 Aye. Any opposed? And any abstentions?
This is Kyra. I'm going to abstain since I wasn't present during that meeting.
Thank you, Kyra. Wonderful. With that, we've approved the June minutes. We can go ahead and move on to agenda item number 4, which is to approve, review and approve the minutes from our August 6th Prevention Subcommittee meeting. Again, just to note that there was not quorum at the August meeting, so these minutes are for information only and no action was taken or recorded as part of the August meeting. So we did receive some informational related presentations at that meeting. When folks are ready, I'd love, if you have any questions, I would entertain any questions or discussion on this item.
Yeah, Chair Johnson.
Mr. Schoen, go ahead.
Yeah, because we didn't have an official quorum. I mean, are they? Do we need to approve these minutes, or are they minutes that we can actually approve? Does that make sense?
Yes, great question. I believe as our folks from SEI did ask this question in advance of this meeting, so I'll turn it over to Kim for the information she has.
We did ask this question, and I would actually defer to our one of our guests who is here. Joseph, would you be able to weigh in on this? Who did provide an answer, but rather than speak for you.
I would have to go back and look at that answer, but I assume I said yes.
You did. So we were told that yes, and individuals who were not present at the meeting are able to both make a motion to approve and second, and can vote to approve those minutes.
Can I, Chair Johnson? Can I just?
Yes.
Can I just say it seems a little odd because it's in some ways it's not. I mean, it's an official meeting in that it was scheduled, but it's not an official meeting in that there was no quorum. So I guess can you help me understand the distinction?
Sure. I'll turn this over to the DAG, who probably has a smarter answer than I do about this.
Give me 1 minute while I try to find the email, because I know that I put a little time into this.
Okay.
Absolutely.
Not meaning to hold things up, but I'm just.
No, absolutely. I want to get your questions answered so you feel like you can vote and review appropriately. While you're looking for that, Joseph and Noel, did you have a related question? I see your hand is raised.
Yes, Noel Shanae, thank you, Chair. My question is very similar. I know I just voted on the June meeting, but I was not a part of the committee, so I am not sure if was even permitted for that vote. So that was my question as well, if I can provide a vote for the August, as well as if I should have even voted on the minutes I reviewed for June. So
Yeah.
clarification there for myself. Thank you.
I appreciate a committee that likes to follow the rules, so I will hold on that question, and hopefully our DAG is able to. I appreciate the research and wanting to be thorough in what was shared.
I cannot find the email, but because the meeting still took place, there still were presentations. So my position, without reviewing the email, is that there still was things discussed at the meeting. We just couldn't take action. So there does need to be a record of that.
Okay, I just thank you. I appreciate you explaining the justification, and that makes sense to me.
Fantastic.
So, and that, oh, sorry, the second part that you had mentioned, I think answers Noelle's question, which is you are able to vote on minutes even if you weren't in attendance at a meeting.
Yes. The OML says, yeah, members that weren't present are allowed to approve meeting minutes, and they're allowed to motion.
Perfect.
Fantastic. Any additional questions from the committee before I entertain a motion to approve the meeting minutes? All right, seeing none, I'd entertain a motion to approve the minutes from the August 6th Prevention Subcommittee meeting.
Chair Johnson, so moved. Eric Schoen for the record.
Thank you. Mr. Schoen, Vice Chair Schoen for the motion. Do I have a second?
Chair Noelle Shanae for the second.
Ms. Shanae with the second. All in favor, say aye.
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 Any opposed? And any abstentions?
This is Kyra Morgan again. I'm going to abstain.
Thank you. I believe the motion carries for approval of the minutes. Thank you for that. All right. Wonderful. Let's move on to agenda item number 5. I've already learned a lot in this meeting and looking forward to learning a little bit more about some of our new subcommittee members. So this is really a discussion item only for the folks who are new to this subcommittee. Really, I want to thank you for selecting prevention and joining this subcommittee, and wanted to provide a brief opportunity to share more of what brought you to joining the SURG, and specifically around the prevention subcommittee. So I was going to introduce members and then in turn turn the mic over to you for just kind of a brief background and sort of what brought you here. Our first new member is Kyra Morgan. Kyra is a representative of the Division of Child and Family Services of the Department of Health and Human Services. I wanted to note that this department has changed names to my knowledge. So it's the Department of Human Services, but in the AB 19 language, this is how it's written. So this is how it's included here on our agenda today. I have Noelle Shanae, hopefully I said some of that correctly, who's an emergency response employee, and Stacy Lance, who's a representative of a local government entity that provides or oversees the provision of human services in Washoe County. So Ms. Morgan, I'll turn the floor over to you if you want to share a little bit about your background and what brought you to the SURG.
Well, I serve as a medical epidemiologist with the Division of Child and Family Services. So my role there is really to study things that are impacting our kiddos, things that are impacting family and safety concerns, and then also outcomes of programs that we provide to families. I've been in this role only for just under 18 months, but I've been with the Department of Human Services for going on 16 years. And from 2015 to 2024, I served as the chief biostatistician in the Office of Analytics. And in that capacity, under Brian Sandoval, served on his opioid accountability task force. And then under the AG at that time, they also had the acronym was SPOC, but it was, I forget what that stands for, something about an opioid task force. And so pre-COVID, I spent a lot of my efforts really ensuring that we have active surveillance systems to capture the magnitude of the opioid epidemic in our communities. And then that got derailed quite a bit when we started having a global pandemic. So I haven't touched it much since. But in my free time, I am also pursuing a doctorate in environmental sciences and health, where my research focuses on gestational exposure to substances of abuse. So I have a pretty deep background in public health prevention and also drug use and substance abuse generally. So excited to be part of the team.
Thank you so much, Ms. Morgan. Looking forward to having your expertise on our committee. Glad to have you. Next, Ms. Shanae Noel.
Thank you for having me. Noelle Shanae, for the record. I'm so grateful to be here. I work as a paramedic and volunteer as a paramedic across 2 different agencies serving rural Nevada as well as that Northern California area. And I also work with one of our prevention coalitions as well, so as a certified prevention specialist. And I really see in my role as a paramedic where prevention intersects, and we can deepen that prevention component in emergency services to better support our communities, especially out here in the rurals. And so that really drove me to apply for this committee, as well as this particular subcommittee to share about those intersections that I see and opportunities for growth within that emergency response and the perspective I bring. So thank you.
Fantastic, Ms. Shanae. Thank you. I am also really grateful to have your expertise on the committee, and I love the additional rural perspective. I think that'll be really fantastic. Miss Lance, would love to hear from you.
Hi, thanks for having me. My name is Stacy Lance, and I'm a division director for Washoe County Human Services Agency. And I oversee part of the child welfare services and programs. There's 2 division directors, so I don't have the front end assessment, but I have the permanency teams. So those are all the kids that are in foster care, working with their families to get them home. I have our clinical teams as well, and so that includes the Children's Mobile Crisis, and then we have 12 clinicians that are sort of embedded and work with child welfare. And I've been in child welfare for 24 years, and I've been in this role just for about 10 months. So I think that probably pretty much answers it. Thanks for having me.
Wonderful. Thank you, Ms. Lance. Looking forward to adding your perspective and expertise on this committee as well. Thank you all very much for being here today, and in advance for all the great work that we're going to do together. Thanks so much. All right. Let's move to agenda item. As I mentioned at the outset, we'll be taking this agenda item out of order. So I'm going to turn this over to, so we'll do agenda item number 7, which is a presentation on substance use prevention allocations. And I'm going to turn the floor over to Stephanie Cook, who is our state opioid treatment authority, who's prepared some slides and a brief presentation for us. And then the subcommittee will have a chance to share some questions at the end. Stephanie?
Awesome. Thank you, Chair Johnson. Let me get my slide deck. Let's see. I don't know that I have the right to share my screen.
Let me know if you have any trouble, and I should be able to give you access.
Oh, there it goes, there it goes. Okay. All right. Okay, so I am here, Stephanie Cook with the Bureau of Behavioral Health, Wellness, and Prevention. We are located within the Division of Public and Behavioral Health, and I'm here to talk about prevention and what that means for us within the Bureau. Okay, about DPBH, our mission is to protect, promote, and improve the physical and behavioral health and safety of all people in Nevada. equitably and regardless of circumstances so they can live their strongest, longest, healthiest, and happiest lives. Nevada, where preventable health and safety issues no longer impact the opportunity for all people to live life in the best possible health. And our purpose is to make everyone's life healthier, happier, longer, and safer. So I've got 3 main points to cover today. I'm going to do a quick overview of our bureau, also referred to as BBHWP. I'll also go over what is substance use prevention, and then talk about some funding sources that we oversee here in this bureau that relate to primary prevention is what we're talking about today. So the Bureau of Behavioral Health, Wellness, and Prevention kind of has 2 parts to it. One side of our house is mental health services, really looking at community mental health services related to the crisis response teams, mental health community services, and then problem gambling is also on our mental health side. The other side of the house is all the substance use programs in which I oversee. These are all different federal grants, state dollars, really looking at substance use prevention, treatment, and recovery services. And so that's where we're going to review some of this information. We manage various federal grants for prevention, treatment, and recovery services. And we also have a small amount, I'd say 98% of our funding is federal grants and about 2% is state general fund. And so we'll talk about what those general funds look like and how they are used in the prevention space, and then review our federal funds that also touch this space. So what is substance use prevention? Substance use prevention is a proactive process that empowers individuals and communities to prevent the initiation of substance use and reduce associated risk. I'm speaking to the choir with this subcommittee, I'm sure. The goal is to promote healthy behaviors, strengthen protective factors, reduce risk factors before problems occur. We do this through a lens, the SAMHSA prevention framework, which is data-driven, evidence-based, community-centered, and culturally responsive. Our guiding model here is the strategic prevention framework that I've linked to this slide. So we'll talk about 3 different domains in prevention, starting with primary prevention. So the goal of primary prevention is to prevent substance use before it starts. The focus here is really reducing risk factors and strengthening protective factors in the various populations that we're dealing with, whether that's youth in our schools or older adults in different spaces. Some examples of primary prevention are school-based prevention education, parent skill building programs, really ensuring that we've got wraparound services in these spaces to prevent substance use, and then media campaigns promoting healthy choices. So it's not just about not doing drugs. It's also about, being healthy and promoting healthy choices in general as it relates to our various populations. For the sake of tracking things within all of our programs, primary prevention is the only type of prevention we explicitly track, as most programs have secondary and tertiary prevention sprinkled throughout. So I get a lot of questions of like, how much money are you putting in prevention? And so I'm focusing this presentation on primary prevention versus all the other stuff, because it's sometimes hard to track or even put a dollar amount on some of this work, right? So for this presentation, the ways we track things in the primary prevention space is easier than in the secondary and tertiary. So as it relates to secondary prevention, the goal is early identification and intervention for those at risk or showing early signs of use. The focus here is to stop the progression to misuse of drugs or drug dependence. Some examples are SBIRT. It's a good way to intervene at a time in someone's life where they may need direct supports, but aren't quite to the point of daily misuse or chronic misuse or dependence. And then early intervention for youth experimenting with substances. So we see this a lot in our middle school youth and our high school youth. They may not have a diagnosed substance use disorder, but perhaps have tried a few things or done a few things. And so really intervening at this point is where the secondary prevention comes in. And then lastly is tertiary prevention. This is reducing the impact of established substance use disorders and prevent relapse. The focus here is treatment, recovery supports, and harm reduction. So some examples are recovery support services or recovery housing and peer support services. We invest a lot of effort and time in peer support because we know it works. But peer support is very much can be used across the continuum in various different spaces. But a lot of times, someone with lived experience is really where the peer support expertise is needed, and that's usually in tertiary prevention, not always, but that's where it usually lands. Medications for opioid use disorder are also an example of tertiary prevention, and then relapse prevention programs. I often think of and explain this to folks as like tobacco cessation too, trying to get someone to stop smoking tobacco after they've been doing it for years, and then really utilizing that tertiary prevention efforts to get that person to stop using tobacco is a good example of tertiary prevention as well. So I'm going to first start and lead into how we use our general funds for primary prevention. So for those that may not know, and some of this language is our lingo, but we know it as this. The state general fund means it comes from the legislature and is allocated through the legislative session every 2 years. So those funds are what we refer to as state general funds. It's given to us usually based on base years, and then it fluctuates based on the governor's recommendations as we get them. And then some of these are revenue accounts that we get certain revenue from. So the first one we refer to as subunit 11, doesn't mean anything to anybody else but us, but it is a general fund account that is in our budget that is only used for substance use prevention initiatives in our community. In this bureau, we have one for treatment and one for prevention, like one account each. And so this account is only for substance use prevention. In the past, it was created due to the issues that we had with methamphetamine in our state years ago. We've recently renamed this account to allow for prevention activities in general. It used to be very specific meth education. We've asked and updated our language to have that more broadly, because we know with the landscape of substance use in our state, in our country, that these things are fluid sometimes. And so we need the flexibility to be able to do substance use prevention in general, not just for specific drugs as they come along. So we utilize this right now to fund these 3 agencies. We fund prevention services to at-risk youth that are already diagnosed with FASD. And that work is done through Grant to Gift Autism Foundation, the Ackerman Center down in Las Vegas. We also provide funding to the Nevada Cancer Coalition to help us with education and resources to retailers in Nevada to prevent underage purchasing of tobacco and tobacco products. And then we fund PACE Coalition in Elko County to provide substance use primary prevention activities in that county. We have another account, which is revenue generated from our certification fees. So for those of you that may be familiar with certification that happens out of our bureau, we certify substance use prevention and treatment agencies and are looking to expand that to other mental health services and crisis support services. So right now, the fees that are generated from those certifications also help fund the actual certifying of the prevention programs and the prevention coalitions that we certify in our state. So right now, that is what we've got going on for general fund accounts for primary prevention. And like I said before, this is only primary prevention I'm talking about, because secondary prevention and tertiary prevention is just sprinkled throughout a lot of things, and we don't necessarily carve it out of our sub-awards with our agencies like we do primary prevention. So next, we'll tap into what our federal funds look like for primary prevention. This is a lot more detailed information and more vast, so I'll go through a few slides related to this. The first is our Substance Use Prevention, Treatment, and Recovery Services Block Grant. This is one of the main grants the Bureau manages for substance use initiatives. It's about $20.5 million a year. It's a 2-year performance cycle. So we've just rolled into our first year of our new cycle, our full cycle, that began October 1st. In this block grant, there is a required 20% set aside from the full grant amount for primary prevention activities. So it is required by federal law that each state that receives this block grant puts aside and applies 20% of the dollars to primary prevention activities. And this includes any state level costs, project supports, and then we also disseminate dollars into the community to certified prevention coalitions or certified prevention programs for primary prevention activities. The block grant, the intention of the block grant is to plan, implement, and evaluate activities for the prevention, treatment of substance use disorders, and to provide recovery support services. And the funding priority for the block grants across the nation is for the uninsured or uncovered benefits as it relates to identifying gaps in states. The intention of this is not to supplement any other funding source, but to really identify where the gaps are and what things are not funded by any other source. So the funding for primary prevention activities in this block grant are, the dollars only go to prevention coalitions and certified prevention programs out in the community. Like I said before, the rest of the dollars, we do support data systems here at the state. We do have other initiatives that are statewide that we apply that to, but the money going out into the community does only go to the prevention coalitions and the prevention programs. The topic areas for primary prevention in our block grant are school-based programming for substance use prevention. I like to bring up to people how the traditional DARE programming that we did back in the day that didn't work because it was very scare-based tactic-y is part of this though. Like it was initially meant to be school-based programming for substance use prevention. But that's a main bulk of a lot of our primary prevention efforts are focusing in on our kids in schools or in various other settings. We participate in drug take-back programs through our community coalitions, education and awareness related to substance use topics, family engagement activities, and then student-led peer groups and activities in our schools. The block grant right now for primary prevention activities currently funds SINAR activities, regional supports, prevention coalitions, and prevention programs as listed in this slide. Oh, wow, this got really messed up. In my slide deck that I will provide and SCI will post, this is a pie chart of our block grant and the related general funds. I will get this fixed and posted in the updated version. So in totality, as it relates to our block grant and all the general funds, as it relates to all substance use, we've got about $25.5 million. And this star right here shows an $8.3 million primary prevention allocation that I will show at a later slide too, but I will fix this so it's not so jumbled. The last thing I'll talk about in the block grant is we recently finalized our strategic plan that really drives our funding on the gaps and needs of our state as it relates to our Bureau in totality. So these 4 strategies listed here, we're all pulled out from our substance use section of our strategic plan. And so all of our guiding efforts on the substance use side will be embedded within these strategies. And this does apply to prevention, treatment, and recovery services. Another federal funding source we have is the PFS grant. We are issued this grant through SAMHSA. It's the Partnership for Success grant. It is a very specific primary prevention funding source set to reduce the onset and progression of substance misuse and its related programs. The state of Nevada is currently funding 3 certified prevention coalitions through this grant. I show on the right side over here that in previous years, our funding source or our funding for this grant was about $2.2 million for a 5-year grant. And SAMHSA restructured this grant in recent years between 2023 and 2024 to allow for other agencies to receive direct funding from SAMHSA. And so it limited the amount of money that the state received because it allowed other agencies within the state to also receive the money. So right now we have a 5-year grant with SAMHSA for this funding at $1.2 million a year. And then we've also got PACT Coalition in our state that receives this funding. And then UNR, University of Nevada, Reno, also receives a PFS grant. So our topic areas, we did a community assessment and chose these topic areas as our focuses for this grant. They will be the same topic areas for the iteration of the grant, really looking at middle school and high school, suicide-related behaviors, vaping, prescription pain medication use, and violent and depressive behaviors as it relates to both middle school and high school. So altogether, the substance use block grant was the $8.4 million on the pie chart that I will get fixed. So you can see that allocation there. The Partnership for Success grant, the full amount of that grant is primary prevention activities, so 1.2. And then our SURG grant, our State Opioid Response Grant, has 3 allocations right now going directly to primary prevention. SOAR is probably the most, is the largest grant that has stuff sprinkled everywhere as it relates to our various entities that we're funding. And so it's harder to kind of track down secondary and tertiary prevention in that space. But right now, the primary prevention allocation from the SOAR grants, $1.3 million. Again, these are annual numbers that we're currently reflecting on this slide right here. So in conclusion, effective substance use prevention activities is not just a single activity. I feel this when I get asked how much, what our allocation is on prevention. Like it's so much bigger than just primary prevention. It really is the integrated lifelong effort that supports individuals and communities at every stage of all this. So the information I've shared here is very much specific to primary prevention and how we allocate it separately because it is a specific carve out to our various funding sources. And then we are also looking to to align all of our other treatment, other prevention activities and recovery into ways that we can display that information that makes sense outwardly in all these different buckets, because sometimes it's not as easy as just a single activity that we can present it in. And that is my contact information. Happy to, if you have questions or concerns or want to chat about anything else, there's my contact information. And I will leave that up.
Wonderful. Thank you so much, Stephanie, for a wonderful, detailed presentation. I'm going to open the floor in a moment to questions from subcommittee members, just noting that specifically, or other members of the SURG who may happen to be on this call. For Stephanie, my request is if you have availability, if you can, much of this presentation is related to a SURG recommendation item that we're going to take in the next agenda item. So I'm hopeful, Stephanie, that you'd be able to stay on and help us maybe wordsmith that as our next agenda item to make sure that it is actionable and appropriate. Subcommittee members, any questions from this very detailed information presented by Ms. Cook? Ms. Morgan, the floor is yours.
Hi, Stephanie. I do just wonder if you guys are tracking, like, I know it's really hard to tie probably prevention dollars to like moving the needle, right? And showing that prevention dollars are actually preventing the onset of substance use. But I'm just curious if there's any data that you're tracking or if there's efforts to try to quantify the impact that the dollars are having on the community.
Yeah, thank you for that, Kyra. Yeah, it's hard. I think prevention is probably the hardest thing to tie back. Prevention has to be studied over a long period of time to ensure, to see the impact. I think our entities do a good job of tracking small wins as it relates to prevention. We are also looking at a return on investment report on both prevention and treatment, all three, prevention, treatment, and recovery services, to really pick out pieces of information that we can track return on investment for, and really start looking at it with that lens. On the PFS grant, we focus very specifically on the YRBS, which is a youth risk behavior survey that you're probably very familiar with, Kyra, and really looking at very specific questions and looking at those questions over the 5-year grant cycle, knowing that that survey, only goes out twice in that 5 years. But really trying to see that connection between middle school and high school and keeping a tab on those kids, even though it may not be the same kids, but at least the flow of that data from middle school to high school to be able to paint just a little bit of the story, right? Because I think the story in prevention is so big, and it's hard to say, look at this $8 million we put out there and look what we did. Like, look at all the people lives changed with it. So always happy. I always learn a lot when I talk to other folks too in other states of like, look, we pin this data point with that data point, and we're able to display this return on investment information and tie the data pieces together. So again, work very closely with our Office of Analytics too on what data points can we pull together to then look at this kind of more broadly as we look at impact.
And can I just follow up really quick? I know there's another member with their hand up, but I'm just curious because I've kind of been out of that space for a while. Are there like specific surveillance reports that are still being produced regularly that we can like self-serve to go look at? Like, I know the Office of Analytics, like 10 years ago, was really working on like monitoring like overdoses and hospitalizations and things that definitely aren't, prevention necessarily, but I'm just curious if you have like links handy that you could share where we could try to track some of that, because I just am trying to get brought up to speed on where we are. It's been a while since I've been in this space.
Yeah, our Stephanie Cook, for the record, our Office of Analytics teams do keep up the EPI profile. And so that's very helpful because it kind of pulls things together every 2 years and into one space. And then on the opposite years, they focus in on various specific projects. So yes, I can share some of that information, and we are working on building out our dashboards. We've had dashboards throughout the years, but really trying to make them useful to like the lay person. It's always hard when you look at a dashboard and you're like, I have no idea what I'm looking at. It looks really good to somebody that may understand it nicely. And so that's why I've requested kind of those return on investment reports, because I think it's easier to be able to pull this information together and like 5 areas that were really making a difference with all these dollars, instead of trying to tie every single dollar to an outcome, right? So we are doing that. I can definitely provide the links for I'll compile some of that information together and send it out probably to the chair, and then we can get that disseminated out to everybody.
Wonderful question. Thank you, Ms. Morgan. Vice Chair Schoen, I believe your hand was up next. Go ahead.
Thank you, Chair Johnson. Stephanie, quick question for you on the approximately 8.5 million allocated for primary prevention. How much of that is federal funding and how much of that is state funding?
I just put in the chat just a snippet of the slide because it was slide 16, so I'm not adding anything to the record that wasn't already there. Primary prevention. Oh, there you go. Oh, it works on your end. So the 8.4 is okay. So if I go back to where's that slide? The 8.4.
And Stephanie, please let me know if you want me to go to any other slides.
I guess I don't have that written out here. I will get that to you. I will say the 8.4, it's about 98% of that is federal funds.
Yeah, that was my impression. I just wanted to, okay, I appreciate that.
our general fund account for that CAT 11 subunit 11 that I talked about on slide slide 11. That subunit 11 amount is about 1.6, and that's for primary prevention dollars. So
Okay.
1.6 is primary prevention state funds
Mm.
a year, and then the rest is the federal funds.
Okay. I appreciate it. Thank you very much. And
Yeah.
actually, one more point of clarification. That 1.6, is that raised through that one of those was raised through certification fees? And is that primarily how those funds are generated, or is that a different mechanism?
Nope, our general fund account is allocated through the legislature.
Okay, all right.
So the legislature decides
Yep.
what we get in that account. Yep.
Okay, perfect.
State cash.
Thanks so
Yep.
much.
Uh-huh.
Thank you so much, Ms. Shonay. The floor is yours for your question. Thank you.
Thank you, Noel Shanae. Thank you for that presentation, Stephanie. I guess my question is looking at the data as it's was identified to create this strategic plan and these funding allocations, and then going forward, is there any crosswalking across departments and thinking about some of the others that may do prevention, might be not primary prevention in the substance use category, but it is the same strategies, right? That community connectedness you talked about, those healthier choices, thinking about like DCFS, et cetera, Nevada Department of Education. Are any of those used to inform these and crosswalk and strengthen? And then alternatively, how is this used to inform agencies like emergency services as they are developing policies, developing education standards for those who are licensed to the state, et cetera? Does this data kind of move throughout the organization?
Yes, Stephanie Cook for the record. So when we did our strategic plan, we hired a vendor and we provided them probably with a list of 50 documents that they needed to take into consideration when they looked at the data, right? So those things included the governor's priorities, right? The governor has a document of his priorities, right? We have the Funds for Resilient Nevada's strategic plan. We've got different counties and all their strategic plans. We've got, other statewide, we have a state health improvement plan for our division. So we took all those things into consideration as we looked at what does the state of Nevada need? Because if all these other people around us are telling us they need these things, then obviously the state needs these things. So we took all those things into consideration. And like I said, we had like a list of like 50 things that, and in my presentation, it also links to our strategic plan, so you can read, it highlights all the various data documents that were utilized. So we did take those things into consideration. The information I presented today is only substance use. So there is a lot of information that came out of the crisis side that looks at, law enforcement trainings, 988 dispatch, and all those kinds of things that also came out of the plan. I didn't present on that today, but happy to share, more on that if needed. We have a presentation for that as well on our plan as a whole. Actually, I think Shannon Bennett might have presented that at the full committee. But we are looking at, so within our strategies here under substance use, each one of these has sub strategies. I didn't want to bore you with all those, although I could send out the entire document that has all the strategies and sub strategies, to where we are looking at intersections between law enforcement, the courts, really dialing into the sequential intercept model as it relates to all these touch points with our judicial systems, our jail and prison systems, really ensuring that, as we look at what our needs are in the state, it's not just the things that we can throw money at right now. It's like, what systems do we need to build, or what connections need to be made between all of our sister agencies, our sister departments. So really looking at those all fall into these strategies just under sub strategies. So happy to share that document too. But we are looking at like low barrier access to medications through our EMS systems, through our hospital systems, you know, trying to invest more in our peers that are in our hospital systems or otherwise. So we are looking at a lot of that through, and not just through the substance use lens, but also on the mental health lens. We see a lot of the, you know, peers were across the board in our strategic plan as needed across all domains. So really looking at all these and then deciding like what, you know, where do we need to invest a lot of our system building tactics and services to get systems to talk together and build things together, and then where can we, you know, put money on the ground that's gonna, you know, make an effort and make a to make a difference like today, you know. So there are things that we're working on that are more system based instead of, you know, something that's gonna work for somebody today or tomorrow.
Thank you. Terry Kearns, who is the chair from the Response Subcommittee, is joining today. So, Dr. Kearns, do you want to go ahead and ask your question?
Sure. Thank you for the recognition, Chair Johnson. Stephanie, thanks for the informative and excellent presentation. And mine is more a comment, and if you want to expand upon it, that would be great. I know that in the past, when you pushed out some of the RFAs for your grants, you highlighted the fact that if any of those applications address SURG recommendations, they would be given priority. So first, thank you for that. We appreciate that for the work that's put into the recommendations. And just if you have any other comments on that, thanks.
Yeah, Stephanie Cook. We also did that for our strategic plan. So we acknowledged that there's, you know, this whole SURG work group that's working on all of these things at the state level, really even higher than like me, right? There's a bunch more out there than just our bureau. And so, yes, acknowledging that the SURG has all this work already being done. My team really works hard to ensure that we're reporting on all the SURG recommendations and really taking those into consideration as we look at aligning ourselves with our strategic plan. And what the SURG is already, you know, already looked at, already invested resources in, and already has done the, you know, the hard lift of recommending, you know, what the needs are that this group and the full group and all the groups, I guess, have really already done the work for and identified where the needs are. I think sometimes those needs look a little different from my lens as having the money in my back pocket. So really helping my team to really see how some of these things may be already happening, but maybe there's ways for us to do it differently or better in order to acknowledge the recommendations of the SURG and previous SURG recommendations as well.
Thank you for that thorough response. Ms. Morgan, I see your hand up again. Go ahead.
So talkative on my first meeting. Noelle made me think about something. And I'm curious, when you had the slide about all of the programs that are school-based prevention programs, I'm curious if those are all focused at students or if there's a training component for school professionals, like school counselors, school social workers, even teachers, coaches, because there's a big literature base now around this idea of like positive childhood experiences really buffering the negative impact of adverse childhood experiences and how those can really intercept substance use. And there's a lot of data, and there's Nevada specific data on like exactly what that dose response is, meaning like the more adversity you have, the more likely you are to use substances, and how you can really kind of cut that off if you have even just like one trusted adult that is important in your life that's outside of your household, or if you have like a team that you're a part of. And so I just wonder if school professionals are getting any kind of training on how they can act as preventative measures from that perspective to kind of cut off that pattern of substance use.
Yeah, Stephanie Cook, that's a good question, Kyra, and I think it's big. As a quick answer, yes, we do. When we look at prevention programming, it's not just the don't do drugs, dare approach, right? It is very much surrounding and in educating the community, and that goes for parents. There's some programs out, some certified certified prevention coalitions that are doing work with youth sports programs to really make sure that we're saturating our communities with healthy decision programming, as a, you know, to not just give that response to our youth of don't do this, it's bad for you, but really helping to build them up, you know, all around with all their various supports for positive ACEs, right? So yes, that work is happening across all of our prevention coalitions and programs. A good example too is the Grant a Gift to Autism Foundation, you know, really looking at those that were already diagnosed with FASD, those youth at a young age, and knowing that just that diagnosis alone puts them at the, you know, the highest risk for substance use later on in life. And so taking them at that point in time and really working with their family, their peers, their brothers or sisters, their babysitters, and really focusing in on all that programming, you know, with those supports, because it's important that we're not just looking at it from, you know, one person's perspective of something, but really looking at those environmental aspects too.
Such a comprehensive response. Yeah, thank you. Thank you, Miss Morgan. Ms. Cook, I appreciate all of your time. I have a couple questions as well. I was wondering if we could go to slide 27 for just a brief moment. And some of the strategies that are pulled out of this strategic plan. And I was wondering if you could share a little bit more kind of about the language that's used here. When I read SUD, from my lens, it's a diagnosed kind of substance use disorder by a professional. And so I was interested that these were strategies included here, and wondering if you could share a little bit more about if that's the correct lens that I should be approaching this with, or if that acronym included here was intended to be different or broader, or how it relates to prevention.
Yeah, and I don't have my document available that shows the sub strategies, but I think if I was to show you that, it would make better sense. I think the main strategy here, like 4.1, reducing stigma and strengthen community engagement around substance use disorders, I think it's not necessarily, I think it's more general to where we're saying the stigma behind whether someone's trying not to do something, or already stuck doing something, or just trying to get help, you know, around substance use disorders, or even trying to understand what a substance use disorder is what this strategy is tied to. So we are then looking at like we're doing an anti-stigma campaign at the state level and having various domains. So one of them will be like youth and parent engagement in various services. We're looking at one for providers, you know, really that intervention piece. You know, people don't want to say anything when they go to their primary care doctor because they know they're not going to get anything out of it, or they're going to be, you know, they're going to be judged on why they're talking about their you know, their daughter found with a vape or whatever that case is. So I think in this sense, a substance use disorder, yes, is a diagnosable disorder, but really it's the stigma around even the education around what that is and what that means. And then same with access and affordability of substance use services. I think in this case, a substance use disorder service could be, you know, is primary prevention as well. I mean, if we're looking at the continuum of services, it's not just treating, it's not just treatment, it's recovery, which is also secondary and tertiary prevention. And then you've got other efforts going on to really ensure that we've got supports across the board in accessing these services.
Okay, thank you for that clarification. I think when I was reading through the plan and in preparation for today, it's definitely something that stuck out to me with my prevention experience. So I appreciate that clarification and really having that full spectrum kind of prevention services at the table in this regard. I also wanted to ask about, you mentioned kind of your ROI, which to me in my head reads evaluation. So I had a kind of a question related to that. So hopefully that's not off base. I was wondering if you could talk a little bit about, as you kind of look for some of these long-term wins or reports, kind of what you're hoping to measure or track. I'm interested specifically if you're hoping to look at reach, particularly for some of these school-based prevention programs or other, that maybe that's an indicator you're already measuring. And if you could talk a little bit more about that.
Yeah, Stephanie Cook for the record. On the prevention side, yes, reach has always been kind of our denominator. I think we're trying to get more creative than just reach, or being able to dive into reach a little bit more. I think there's better data that we can then pull out of who we're reaching and what's happening with that reach. But I do think that reach has always kind of been our denominator. We're also looking at outcomes like positive outcomes as it relates to some of our youth groups. So we know, if we can engage youth in youth programs at a younger age and have them really be peers in this space, that we can flourish that and help that grow and really grow this this culture in our schools that it's better to be, healthier and doing the right thing. So we're looking at those kind of approaches. I don't know, right? I don't have the answer right now of what that ROI is going to look like on the prevention side.
Yeah.
But yes, diving into reach, I think, is where we need to get to, of like who we are reaching and what's really happening.
Yeah, definitely. And I hear you bringing up important things like school climates and other indicators that really positively contribute. I know, I'm sure you're aware, one of those major long-term wins for prevention over the last decade has really been that reduction of kind of most substance use for youth, both vaping and cannabis use aside. Really, I mean, I think that's been a major win as we've been tracking it in the YRBS. So I imagine you're looking for more opportunities like that in your measurement.
Yes, and we, alcohol too. Alcohol has gone down with our youth throughout the last couple years. And so, for example, trying to pin less alcohol use in our youth will save them so much money in college, or, trying to pinpoint these return on investments for people to really understand what that even means. Like, what does it mean when 2% of 2% less of middle schoolers are drinking these days, when people have this idea that everybody's drinking, right? So really taking that data and saying, okay, so now how can we pin other data sets to this? What kind of money or lifelong decisions are we saving based on this percentage decrease in alcohol use?
Yeah, thank you so much. Just kind of one final comment, I think, to your point, is that really primary prevention at that policy and community level, when done well, right, is the absence of many of these things in our community, the flourishing, if you will, and identifying ways to really measure that. It sounds like in that investment is really where the Bureau is hoping to go as you think about this long term. Great. Thank you. Any other questions from subcommittee members? I am loving the engagement today. Seeing none, I'm hoping, Stephanie, you can stay on and help us with our wordsmithing for agenda item number 6, which we'll move to next. So this is our opportunity to discuss the proposed 2025 subcommittee recommendations. So for my new team members on here, I know you all were briefed on the SURG and kind of where we're at. So my hope today is that we will review briefly the recommendations process. I'll turn that over to Kim in a moment, and then I'll introduce what we have so far as our 2025 recommendations, and hoping to get everyone's ideas and discussion going from that. Kim, do you want to review the recommendation process briefly?
Yeah, so just quickly, the process is that we do have a SurveyMonkey set up. That link should have been shared with folks, but if that does not sound familiar to you, that's okay. I will send that link out again. That link that you'll be provided with is something that you can use to share any recommendations that you like. That does include being able to elevate recommendations previously shared and included in prior reports. That is actually 2 of the 3 recommendations that are currently under review by this subcommittee are recommendations that were included in prior reports that the subcommittee decided that they wanted to re-elevate and refine to make them more actionable, so that they could continue to be included, and again, be elevated. So that is absolutely something that can be done. So we do ask that you fill that out. One of the things is that SurveyMonkey requires submissions to almost, or entries to almost every field in order to be able to press submit on there. You don't have to fill out every area. Some of them are quite hefty and can be a little bit overwhelming at first. You can go ahead and just put an asterisk, put a question mark, put a Kim, please contact me, and I'm happy to work with you to help fill out the entirety of that SurveyMonkey form. So that's what you can do to fill out that form. All subcommittee members are encouraged to submit at least 1 recommendation. So that is that. The timeline, would you like me to cover the timeline as well, Jessica?
Yes, I would. I just wanted to add one component to that. Thank you so much, Kim. I guess I wouldn't want the form to stand in the way of a good recommendation and good idea. So I appreciate SEI's opportunity to help support anyone who has a recommendation they'd like to move forward, but for whom the form is feeling like the barrier to submission. Ms. Morgan, did you have a question about that?
Just that I don't remember seeing the form, so I would love to get a refresher email on that in case I missed it. Thank you.
I will send that out this week to everyone, not just the new members. Yeah.
Thank you.
Those links are subcommittee specific, so I will make sure that you get one for this subcommittee.
Go ahead.
Yep. So the timeline is that, which is different for this year, and will be on a new cadence moving forward. So in the past, January of every year was when the annual report that included the recommendations was approved. In January of this year, we're going to be putting out a progress report. That's going to just describe progress to date and really describe the new cadence that the SURG will be working on moving forward, which is that we are now working towards July of every year being the timeline at which the new annual report will be produced. So we have a little bit of extra time this year. And so that's the new timeline we're working on, is that by July of next year, you can see the timeline on the screen right now. That is when the annual report with recommendations will be approved. So with that in mind, and about 20 minutes left in our meeting today, I'll turn it back to Chair Johnson to go over recommendations.
Fantastic. Thank you so much, Kim. I think that means we have a lot of work ahead of us this winter and spring. And if you have folks that you would like to come present related to recommendations that you're submitting, getting those on Kim's agenda earlier so we can have them come present early in 2026, I think will make us most successful together as a committee. So thank you. Fantastic. I'm going to now review and just share out the recommendations currently submitted and hoping to have some dialogue, particularly for anyone who is part of the ones that were submitted on today's committee and open to questions from the subcommittee. The first one we have on the next slide is related to our a proposed recommendation that was submitted around primary prevention funding. And you'll see here that there have been some edits to this recommendation submitted through the form that Kim mentioned related to what was previously submitted. So you'll see here anything that is in underline was submitted by Eric Schoen, and then anything there was additional refinement proposed by myself to this particular recommendation. So I'll pause here for a moment so folks can just see those changes. But the next slide incorporates all of them into the current recommendation related to doubling the amount of investment in primary prevention programming. So given today's presentation, I wanted to maybe first open the floor to Stephanie as a subject matter expert who prepared a very thorough presentation related to this. To see if there are any, really, I think this committee comes with the expertise that we have, but there are opportunities always for refinement. So I'd love to hear, Stephanie, if you have anything that's in here specific. For example, if we got the name of the entity incorrect, would be helpful for us to know. And then any additional details or questions that would be helpful in making this actionable.
Yeah, Stephanie Cook for the record. The first thing I'll say is SAPTA, anybody that knows SAPTA is no longer a thing anymore. So
Okay.
SAPTA used to be our bureau. So anytime you see our bureau name, that's SAPTA. So we've expanded past SAPTA and we're now the Bureau of Behavioral Health, Wellness, and Prevention.
Okay,
So
thank
I
you
would
for
just
that.
take out the word SAPTA. Yeah. Okay, so right now I think my suggestion is some of the wording here talks about not being at the expense of existing programming. If I was today to double my primary prevention allocations, it would be at the expense of existing programming. Because that's not what's currently budgeted for the next 2 years. Also, I think I'm curious to just understand the funding should be the state of Nevada's contribution to prevention efforts. That to me reads our general fund accounts. So as we look at what it takes to increase our general fund accounts, it's lobbying and advocacy at the legislative level. We present our budgets and are told by usually the governor's office or the governor's finance office that it's a base budget is how our budgets are built on our general fund accounts. So I can't just double that because of the way we do budget builds for the executive branch.
Got
So
it.
so just as an idea, if we're trying to get general fund allocations increased, that's got to happen at the legislative level, not mine.
Okay, thank you so much for that. That is exactly the type of insight that we are hoping for, so I really appreciate it. Vice Chair Schoen, I know some of this was some additional wordsmith that you added. Do you have any thoughts on what was shared?
What? No, maybe, but I actually really just appreciate the clarity that I have now after hearing the presentation. Excuse me. My understand. So really, the intent of this was because federal funding you don't have control over. It's going to be whatever allocation you're able to secure with the various grants, and that's going to vary depending on federal priorities. So the intent when this was first made was we wanted the state, the general funds. And so we had a presentation previously where I think now we were conflating both totals into a $12 million, which makes sense. But it's actually closer to 1.6 or 1.8 million for the general fund. It's much, much lower. So if the current level of investment is 1.5, actually it's even less, 1.5 million. Is that correct? 1.8, 1.5?
1.6. I'll get you the real number, but
Okay, so
1.6-ish.
let's say it's 1.6. This would be raised to 3.2 million, but to your point, so I actually was curious if you guys have discretion over how much of the general fund you put into primary prevention, or if it's a strict, this is what the legislature says goes to primary prevention, this is what you get.
Stephanie Cook for the record, because this line item in our budget is for primary prevention, we build our budgets based on the base budget year, right? So if we want that increase, it's got to be through the legislative process.
Okay, and then the reason for the line of this should not come at the expense of existing programming is we didn't want to rob Peter to pay Paul. That was very important to us, that what we wanted this recommendation to be was a strong declaration that investing in prevention is very important to the overall health of and vitality for Nevada. So that's what we're trying to accomplish here. So we don't want to put undue pressure on the department or you guys who are trying to do really great work, but we do want to imply that this should be increased. And so knowing what we know now, I think 12 million is we should be looking at the general fund dollars that are contributed by the state. And then to your point, Chair Johnson, that gives us now a point of advocacy through the legislature, so that then Stephanie and her team, hopefully in a future biennium, could have more prevention dollars from the general fund.
Thank you, Mr. Schoen. I appreciate that summary. And it makes me, I see Dr. Kern's hands raised. I'm going to take it one moment. To me, it seems that this recommendation might be better served, directed as a BDR, like that we recommend a bill draft request. To, maybe y'all can help me out, to whom, to double the amount of the base for primary prevention in the general fund, specific to the line, the account you shared earlier, Ms. Cook. And then like really with the additional language here, wordsmithed related to the 0 to 24 funding allocations. Either annually or biannually. I think that would be a great opportunity for discussion, and including, again, not at the expense of existing programming, and opportunities to use the local lead agency model. So I do think that perhaps based on this discussion, there is a different audience that this could land on.
And Chair Johnson, just one, if I may,
Go ahead.
one other, what I remember when we were sort of discussing this earlier, we would want to be very specific that we want this to start in the next, whatever year we want to start, whatever biennium we want to start, because we just had the next biennium and we were too late. So we would try to be a little bit more specific that we want this to start effective this date for this biennium.
Fantastic. Thank you, Vice Chair Schoen. Dr. Kearns, go ahead.
Yeah, thank you for the opportunity. I have a question, I guess, for the prevention subcommittee and then for Stephanie as well. Probably the majority of the prevention funding comes from Stephanie's division. So is that all the funding that you want to target on this to the prevention subcommittee? And I guess what I'm getting at is there other funding that you might want to look at, such as funding that's coming out of the Fund for Resilient Nevada? And are they doing any crosswalking between those two entities, or perhaps maybe some prevention funding coming from Child and Family Services as well?
Thank you, Dr. Kearns. Before I turn it over, I would love to hear if there's some crosswalk opportunities between the Fund for Resilient Nevada related to primary prevention programming. My understanding is really our original intent of this was to expand the primary prevention program specifically for that 0 to 24-year-old related to evidence-based prevention programming. And I know this originated out of several years of discussion with a former committee member, Ms. Nadler, who's very passionate about expanding the school-based prevention programming. So I think that's a great question. I'd be interested, Ms. Cook or Vice Chair Schoen, if you have any thoughts.
Chair Johnson, just to add also what I remember is that we wanted a regular commitment, if you will, skin in the game, significant skin in the game on the part of the state, independent of the vagaries of either increasing or decreasing settlement dollars or grant dollars, that there would be this solid base and a commitment at a very real level that prevention is important. And so part of that was trying to ensure that there was a significant amount of general funds that were being contributed to these efforts. That's what I remember. Maybe it's slightly different. You have a different memory, but that's what I'm remembering.
Yeah, I agree. So that I think sort of answers Dr. Kern's question that we do want to direct it towards those state dollars. Uh, um, just to be kind of more specific in that regard. And from what Ms. Cook shared, it sounds like the changes to whom this recommendation is directed and specifically for what. I think we have more information from today. Ms. Cook, is there anything you wanted to comment before I take the next subcommittee member's question?
No, I think that's right. If you're looking to target the the prevention general fund dollars, this will be where you're doing that because the FRN already has the ACORN that kind of informs their funding choices. So yeah.
All right. Thank you for that input. Ms. Shanae?
Thank you. Sinead, just wanting to say I feel like my thoughts are being read because some of my question was considering the FRN dollars, some of the different tobacco settlement, et cetera, and how that plays in to this proposal. So I really appreciate that. The second part of my question, though, and Ms. Cook, you may be able to answer this. Is there any of these funds or these general funds identified as match if that we're referring to here? Do the block dollars require match? Is that what we're looking to increase from this general fund? Thinking that this number might be tied somewhere else that we need to consider.
Stephanie Cook, for the record, all of our general fund dollars for substance use are considered maintenance of effort on our block grant. However, I don't think that causes any issues here if you're just looking at increasing the dollar amount for prevention. I mean, it would increase our maintenance of effort, but that doesn't mean there's no complications there.
Okay, just to clarify, it's not a percentage that's required for that maintenance of effort, so it could be equal. Okay, thank you.
It's a complicated formula, but it's not a percentage.
Thank you. We have time for one more question related to this. Ms. Morgan?
I just wanted to chime in on the Fund for Resilient Nevada, just to say that, like, I don't know that it necessarily fits in with this recommendation because it's not general fund, obviously, but it is like really stable funding, I think, for like at least 20 years. And I do think that prevention is one of the priority areas that's allowable under Fund for Resilient Nevada dollars. So maybe we can loosen up the need for it to be general fund, in order to enhance the support if we wanted to, make a pitch for FRN funding.
Thank you for that recommendation, and perhaps this can be wordsmithed with some specific recommendations. So if it's related, doubling the state general fund related to this line item, and specific recommendations related to the FRN prevention funding could be a strategy, or could be an additional recommendation for what exists in that plan at the moment, or reaching out to the ACRN for some additional input related to this. Any additional discussion or questions for Ms. Cook related to her expertise on this? I know we're getting a little close on time. I'm really loving this discussion on the committee, so I have just been really energized. Or Ms. Cook, any final thoughts based on what the committee shared today from your perspective?
I just wanted to say something based on what you just said about maybe having a dual recommendation. I think that's hard. When we look at, you know, whether you're meeting or whether a recommendation was met or not, when you have like this and thing happening. So I would, like you said, either do two separate recommendations or just not do that, because I think some of these from previous years have just been hard to track when it's a this, and this. And you're like, well, I did one of them, but I don't know about all five. And so I would just try not to do dual recommendations in one, because it's hard to say you did it or not. But no, I appreciate this. I think this was helpful for me to understand what you're trying to get to. Because I've been at the state 19 years, so I know how all this bureaucracy goes and how this all kind of plays together. So happy to chat about, I'm hoping I can be helpful to some of these ideas and how we can better get there, and based on what the need is and what the ask is.
Thank you so much, Ms. Cook. We're hopeful to get a recommendation to you in time for something to be actionable either by your group and or the legislature to help move this recommendation forward. So thank you so much for that. I'm going to move to the next proposed recommendation, just to read in to the record. So we had a presentation at our August subcommittee from the Board of Pharmacy related to naloxone in hospitals. And we had a presentation earlier in 2025 from the California Bridge program and a local emergency room Dr. Kelly Morgan, local to Clark County, related to naloxone dispensation in emergency rooms. So a recommendation that I've submitted that's new this year is to request guidance from the Nevada Board of Pharmacy posted to their website and communicated to pharmacists to clarify regulations pertinent to the distribution of naloxone in hospitals, to permit low barrier naloxone distribution from EDs, and permit EDs to adopt a naloxone specific standard operating procedure for public naloxone distribution that's separate from and exempt from the regulatory framework surrounding hospital formulary medications used in patient care. This is current wording for this. I wanted to read it out today. I know that we're short on time for discussion, but would entertain a question from the committee. And I guess I'm interested in, would you like more discussion around this before we vote on this to be part of a recommendation? And if you'd like more discussion, I'm happy to schedule such at our meeting in February. Ms. Morgan?
I think just in the interest of time, I would recommend more discussion at the next meeting, but just so I understand, are you saying that emergency departments are not providing naloxone to a person that comes into the ER without like admitting them and then charging them for the ER visit? Is that is that what we're trying to change, is to make it similar to a pharmacy where you can go into an ER similar to an over the counter and get it like open access? Is that the spirit?
Great question. For brevity's sake, we'll plan to discuss more in February. There seems to be a gap in information for hospital pharmacists about if they can provide sort of what I would call community-based naloxone distribution and what that might look like. The Nevada Board of Pharmacy came on and gave a really great presentation related to this. I think having some formal guidance and communication for pharmacists to make that actionable would really move this forward. So we'll entertain more discussion in our meetings in 2026. And then just the other recommendation that was submitted by a former committee member, but it is an elevation of a recommendation from our 2024 report, is related to allocating additional funding, cannabis retail funding towards cannabis prevention using a local lead agencies model. So we're hoping to bring a presentation on this from a subject matter expert in the new year to share more about this specific recommendation. In the interest of time, I'll move to agenda item number 8. The full SURG will be meeting, so discuss a report out for the January 2026 SURG committee meeting. At the large meetings, usually we provide a subcommittee report. So I'll plan to lead this agenda item in January, summarizing this very excellent and engaged meeting today, and the progress that we've made since the SURG meeting in October related to these recommendations. So just wanted to discuss that here with the subcommittee. Any questions about this related to the January 14th meeting? All right. Seeing none, we'll move to agenda item number 9, which is our final period of public comment. I'll turn it over to Kim to ensure that we're open meeting law compliant with any additional questions related to public comment.
Right. This is a period of public comment. Public comment will be received via Zoom by raising your hand or unmuting yourself. When asked for public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter. Oops, sorry, I realized I did not progress the slide. No action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken. If you are dialing in from a telephone, dial 253-205-0468. When prompted, enter the meeting ID 825-0031-7472. Please press *6 so the host can prompt you to unmute. Members of the public are requested to refrain from commenting outside the designated public comment periods unless specifically called upon by the chair. Additionally, please do not use the chat for items other than technical support, as this becomes part of the public record.
Fantastic. Thank you so much. Do I have anyone for public comment?
I do see 2 individuals.
All
I do
right.
believe Jamie Ross was first, followed by
Fantastic.
Sherilyn Rawwood.
Thank you. Jamie Ross, you've been recognized for public comment.
Thank you so much. Jamie Ross for the record, ROSS, and I am public commenting on behalf of a member of the ACORN, and am hopeful that potentially the chair of this committee, as well as the coordinator for this committee, Kim, could work with folks on the ACORN, as well as the coordinator for the ACORN, which I do believe, I cannot remember who this lovely young woman's name is. Hopefully someone else remembers it, but would love to collaborate on potentially looking at specific to your recommendation on doubling prevention funding. Would love to connect on that and hopefully have that be a collaborative effort between ACORN and SURG, assuming I am lucky enough to be reappointed to the ACRN, as I have not yet been reappointed.
Thank you, Ms. Ross, for your public comment. Next, I'm recognizing Sherilyn Rawwood for public comment.
Yeah, Sherilyn Rawwood for the record. Director of Behavioral Health for Nevada Rural Hospital Partners. As you guys are looking at that naloxone piece for the ED departments, One thing I know the critical access hospitals are looking at is making sure or being able to hold the medications for our MAT treatment, especially for those who are getting put on a prescription but live in the rural region. Say they get out of jail in a rural region, or they get discharged from a hospital in either Washoe or Clark and get sent home. Sometimes it's hard for them to fill those prescriptions with that medication. So that might be something that you might want to look at and kind of double team or write another recommendation for that. So.
Thank you for your public comment. I appreciate that. Any additional folks for public comment?
I do not see any additional public comment.
Thank you. I want to just take a moment in this public comment period to recognize Eric Schoen and Angela Nichols from this committee. This is their last meeting as part of the prevention subcommittee. Wanted to extend my gratitude for their hard work and opportunity to move forward some pretty potent recommendations and impact across the state of Nevada and in their work. I thank them for their time served on this subcommittee and hope that they'll continue to be involved in their professional capacities to help us move this work forward in the community.
Thank you so much for those comments, Chair Johnson, and right back at you. It was a pleasure and a joy to work with you, and to the new committee members, this is a great opportunity to really make, I think, a significant difference in what can be achieved for Nevada. And so I'm excited to see what you guys will do next.
Thank you so much. We'll go ahead and close this period of public comment and move to agenda item number 10 for adjournment. Thank you all for your time today and my gratitude for joining us. Take care, everyone. Talk to you all again soon.
Bye, everybody.
Yeah.
Bye.